is preparing the patient for surgery. So what I'm going to, in over the next 10-15 minutes, going to familiarize you how we prepare the patient. So when a patient, obese patient walks into the clinic, what is it that should be in your mind to prepare this patient for undergoing a bariatric procedure as the life thereafter? The patient needs to understand the disease and needs to understand and accept the fact that the patient has a disease. So they have faced a lifetime of discrimination where somehow they, all of them will feel that this problem is something that they have brought on to themselves. So you need to nullify that. You need to make them understand that this is a disease, that to treat this disease, what is the need? Why do they need surgery? When is it that surgery is the option to treat obesity? What are the various surgical options? And how the patient needs to be prepared for surgery and the life thereafter. So what is obesity? Maybe you have already undergone, there's going to be a lot of repetition, but since I've prepared it this way, let me go through the motion. Obesity is a disease of excessive fat storage. It is multifactorial. Pathophysiology includes a genetic predisposition. Over the years, humankind has faced long durations of famine, and so the genes, survival genes, are the ones which were thrifty. And therefore, though we all carry those genes, and some of us are more predisposed to storing excessive fat and therefore gaining weight. Environmentally, today the environment is such that there is comfort in performing everything. You just need to place an order on your mobile. You will have the taxi at your doorstep. You will have your food, groceries, everything delivered. Even you may have walkers taking your pets out for a walk. So the environment itself has become obesogenic. The phenotype, the sort of exposure that a developing fetus had in the mother's womb. Initially, especially in countries like India, where female nutrition may be good in metropolitan cities, but in the vast interiors, women are still given a secondary choice for the most nutritive foods, and therefore the growing fetus always faces a challenge in nutritional development, and therefore as a survival benefit will have more of fat. You've heard of the thin fat Indian baby. So for grain, the survival is to have more fat in the body. So those are the phenotypical changes which are there. And then finally, of course, the lifestyle. Again, our lifestyle. All of these contribute to an obesogenic environment and increased incidence of obesity. And most important, obesity is associated with severe comorbid conditions, something which has already been talked about, which affect not only the quality but the longevity of the patient. So how do we treat obesity? And when do we decide what is the best treatment option? For that, we need to quantify obesity. We need to know what is average weight, what is overweight, when do you call a person obese, when does the obesity become severe and finally morbid. So morbid obesity is when obesity per se itself is detrimental to the health of the patient, irrespective of whether the patient has any obesity-related comorbid conditions. So to measure that, the body mass index is the standard parameter used globally. It is not very accurate because there may be persons who are bodybuilders who will also have a very high BMI. But for them, the lean body mass is higher in proportion. But overall, it is a simple parameter to calculate, is standardized, will not vary in the manner it is calculated, whether you are in Japan or whether you are in the Americas. So BMI or body mass index is a parameter which is used, and it is calculated by dividing the weight with square of the height in kgs or pounds, in meters or centimeters respectively. The other more accurate forms are waist-hip ratio, but here fallacies will arise because where exactly is the waist being measured, where exactly is the hip being measured, so fallacies will be created there. or a body composition analysis. Now, body composition analyzers are complex and are high-end machines which may not be easily available everywhere. So, depending upon the body mass index, you can classify the patients into average, overweight, obese, severely obese, and morbidly obese. And this differs, it has been mentioned before, between the Caucasians and the Asians. Why in Asians it is lower? Because metabolic comorbid conditions come or arise in these patients at much lower BMIs. So as you can see, less than 25, less than 23 for normals, and so on and so forth. So how do we determine? In Caucasians, a BMI of more than 35 with an existing comorbid conditions, and for Asians, a BMI of more than 30 to 45 with existing comorbid conditions. These are the patients which will become eligible candidates for bariatric procedures. But we must not forget that about the comorbidities. There is not a single organ system in the body which is not adversely affected by obesity. These comorbid conditions cause severe morbidity as well as decrease in the longevity of life. Some of them being such as type 2 diabetes, which will be discussed more in detail, coronary artery disease, chronic renal disease, COPD, obstructive sleep apnea, and most important now is cancer. So there are 13 cancers identified which have a higher incidence in the obese patients, especially breast cancer, endometrial cancer, lung cancer, esophageal cancer. All of these, there is a higher incidence and and a strong relation with obesity. So these are also become clear indications, and this is what we talk about metabolic surgery. So patients who are prone to these metabolic complications that lower BMI, the level at which the indication for surgery has been reduced both for Caucasians and for Asians at more than 30 kg per meter square for Caucasians and more than 27.5 kg per meter square for Asians. Again, somebody had asked, it is the American Diabetes Association guidelines which have said that patients of type 2 diabetes who are poorly controlled on medical management are eligible for bariatric or metabolic surgery. But we must not forget that the foundation of a successful outcome lies in lifestyle modification. Even when we talk about bariatric surgery, these surgeries are lifestyle modification surgeries. And just undergoing a bariatric procedure does not tantamount to a successful outcome. These patients have to be prepared of the lifestyle changes which are mandatory for a successful surgical outcome as well. So the different procedures which are available, they have evolved along a restrictive and a malabsorptive and a combined element, which include the vertical sleeve, the Roux-en-Y, bigger pancreatic, and the one anastomosis or mini gastric bypass, of which we today here are going to discuss more in detail the Roux-en-Y gastric bypass. So there are laboratory parameters which need to be evaluated for these patients, which include the complete blood count, the entire blood works, which especially in this is measuring the blood sugar, fasting PP, as well as the glycosylated hemoglobin, the serum lipid profile, the serum protein levels, a thyroid function. Apart from that, of course, the functional status of the patient needs to be evaluated, especially from the point of view of cardiorespiratory reserves. These patients are very high-risk patients, and often the higher the BMI, these patients will require preoperative optimization. So all these investigations are done not only to evaluate the functional status of the patient, but also to determine their nutritional status. Just because a patient is overweight does not mean that there will be no nutritional deficiency. Obesity is a form of malnutrition. So these patients do have pre-existing nutritional deficiencies, extremely important to evaluate that. The management of these patients has to have a multidisciplinary approach. And a multidisciplinary approach requires a good bariatric physician on the team, psychological screening, so a clinical psychologist for counseling these patients and for hand-holding over the perioperative and post-operative period, and nutritional counseling. Because again, all these will equate to helping the patient modify their lifestyles. Now, we've all heard about enhanced recovery after surgery, or ERAS guidelines. These were initially begun for colorectal surgery, but soon it was realized that applying them for bariatric surgery would also lead to an enhanced recovery and a better outcome for these patients. So in 2016, the first ERAS guidelines for bariatric surgery were published, and recently in 21, the updated guidelines have been published. These guidelines include the pre-admission, pre-operative and intraoperative recommendations to improve the overall outcome. Now, in pre-admission, when the patient comes to you, there is a... So in this, again, informing a well-informed patient. The patient needs to know about the surgery, how the surgery is going to change, because it is going to be a change for life. So they need to know exactly what is it that they are going to undergo. The indications and contraindications should be according to the global and national guidelines, all updated, and one should stick to it because a lot of medical legal issues are involved in this. Cessation of smoking and alcohol, extremely important. Smoking, especially for the perioperative outcomes. In alcohol, it is important to make them understand that one of the causes for an early relapse is alcohol consumption, because alcohol consumption is empty calories. It results in poor weight loss, and also because a certain segment of the bowel is bypassed. The alcohol digestion is again is altered, and the impact of the alcohol on the liver is expedited. So increased intake of alcohol makes these patients post-bariatric surgery more prone to liver damage due to alcohol. So this all the patients need to be well versed with this. A patient who is in a pre-operative weight loss phase is going to do well post-operatively. A patient who is in a weight gain will do poorly. This is something which has been documented over several studies. So that is the basis behind starting the patient on a very low-calorie diet, because it helps surgically not only by decreasing the size of the liver, but also in the overall weight loss of the patient. Pre-operative, again, a lot of these patients, pre-operative fasting, it has been seen that continuing fluids till about 2 hours pre-op helps in the volume balance of these patients. The only note here to be careful about is patients on diabetes with gastroparesis. Out here, the indication is not clear, and it is better in these patients to have a 6-hour pre-operative fasting. Carbohydrate, again, the recommendation is weak, but for post-operative nausea and vomiting, a multi-moding approach is important in terms of whether we give dexamethasone to the patient, and we give antiemetics, and of course, the use of propofol in these patients, because on these there's a decreased association of post-operative nausea vomiting, and post-operative nausea vomiting is detrimental to the surgical procedure itself. So, for the perioperative fluid management should be such that the patient should remain normovolemic. Colloids do not have an advantage. Crystalloids should be used. The anesthetic protocol should be such that opioid-sparing anesthesia is what should be used in these patients, because a lot of them will have obstructive sleep apnea, will have hypoventilation syndrome. So in all these patients, regional anesthesia in the form of blocks helps in decreasing the overall requirement of analgesia, helps in early ambulation of these patients. Airway management is primarily using endotracheal intubation. Ventilation strategies, low PEEP values. A good neuromuscular blockade helps in surgery, but a complete reversal is important to help in early ambulation. Surgical technique, of course, laparoscopy is the key word here because it decreases the surgical trauma, has been responsible for the high rise in acceptance of this procedure in treating these patients. And again, during the learning curve, it is important for the novice to have a senior surgeon mentoring the trainee while performing the procedure. Abdominal drainage, especially nasogastric drainage, is discouraged. So the ERAS pathways helps in expediting the overall recovery of the patients. This maintains the post-operative physiological functioning. There is reduced morbidity, both short-term and long-term. There is improved recovery. The length of hospital stay has been shown to be reduced, and the overall medical costs are also reduced. In our center, this is the protocol we follow. When the patient walks into the center after an initial consult with the surgeon, it is the bariatric coordinator who takes over. The bariatric coordinator will explain the surgical steps, will explain the entire experience that the patient is going to have. It will be the one who will decide whether the patient is a surgical candidate or a non-surgical candidate. A non-surgical candidate is referred to the obesity clinic, where a multidisciplinary team manages the patient. A surgical candidate is then evaluated, as I mentioned earlier, with the pre-anesthesia management investigations and the required reference. The non-surgical patient found here is again referred back to the obesity clinic, and for the surgical patient is then admitted, undergoes the surgery, and is handheld by the coordinator till the time of discharge and follow-up. So to conclude, a well-informed patient is as much of an asset as a well-organized team with the appropriate infrastructure for a successful outcome. Thank you.